We're going to count down some of the top stories from the AHA this year, a very exciting meeting. And at the number 3 spot, there was a bit of a surprise study called FREEE. This was one of the first randomized trials that I've seen of payment innovations, where Aetna sponsored a study where half of the group, about 3,000 patients or so, were given free medications post-MI, as opposed to the normal co-pays that they got during, with their insurance. What they found was better compliance with ARB, statins, and beta blockers in the patients who had free care for their medications. And they showed a lower rate of death, MI, or stroke. Their primary endpoint included revascularization that just trended favorably. And then costs also were not increased and numerically were actually lower. And so here was a study showing that by changing the payment structure, you could improve quality of care and outcomes and yet make it less expensive potentially. And so a very exciting new study. Now at the number 2 spot were the lipid studies. There was a panel of 3 presented that looked at high-dose statins, finding equal outcomes with atorvastatin 80 milligrams and rosuvastatin 40 milligrams. I think that opens the door to using more atorvastatin 80 when it's generically available. Then there was the long-awaited AIM-HIGH results. This was a study of niacin, although they allowed titration of the LDL therapies in the background, and found no difference in outcomes. It was a moderate-sized trial, but had a lot of endpoints, but turns out had very little difference in the HDL. There were just 4 milligrams per deciliter difference in HDL in those getting the niacin strategy. And so it shows that raising HDL is a tricky business. There is, fortunately, another large trial, the HPS2 THRIVE trial of 25,000 patients of niacin with an anti-flushing agent added to it versus placebo on top of statins. And I think that will provide the real answer. But for the moment, probably a little bit of a pullback in terms of using niacin. Then an intriguing study of a new CETP inhibitor, Evacetrapib, that across several doses, this was the initial dose-ranging study, could raise HDL by more than double and also lowered LDL. So very early going with that agent, but very exciting. And at the number 1 spot was the ATLAS II TIMI51 trial that looked at a very low dose of rivaroxaban and found a mortality benefit. This was a post-ACS study, started at around the time of discharge, in patients who mostly got dual antiplatelet therapy, all the other standard treatments, and were randomized to one of 2 doses of rivaroxaban, 2.5 milligrams twice a day or 5 milligrams twice a day or placebo. And they found a significant reduction in cardiovascular death, MI, or stroke, and a reduction in mortality, both cardiovascular and total mortality at the 2.5 twice a day dose. Now, this is really an unprecedented degree of mortality benefit. As we know, ticagrelor has seen about a 20% mortality benefit, and so some big advances of late. But one thing to bear in mind here, that this is an anticoagulant, and so bringing back both antiplatelet and anticoagulant therapy. But it is not triple therapy as that has been known of late. The dose, 2.5 milligrams, is about 1/4 the dose of full anticoagulation. And thus it's not what we've been using in the patients with AFib who get a stent, where one has to use full dose warfarin, and we've been wondering about other full dose of the new anticoagulants. And so this is an important advance for ACS patients. It opens the door, I think, to further testing of the dual indication patients of AFib and stented patients, but that group really needs further studies. It's a different type indication. And so with that, I think the meeting was all abuzz, talking about the different therapies in ACS and lipid prevention, some of the new innovations. And so really one of the most exciting AHAs we've had in many years. So for CardioSource Video News, I'm Chris Cannon.